All right, we got it.
And then.
All right, everyone, we're gonna start. Sorry, the tech things are always a thing. This is Dr. Nuzielli. He is from pharmacy. He's gonna talk to us about psychiatric disorders and drugs. Hopefully, you guys saw the Zoom link for the recording and you have watched some or all of it. And then I'll let him do a little bit further introduction and introduce himself better. But enjoy. He's come several years in a row, so we always appreciate him coming.
Yeah, I think this might be like the 6th or 7th year in a row. It's been a while.
Yeah.
I think it's time to pass it off to another pharmacy.
Nope.
No, I'm kidding. I'm kidding. I actually really like it because you guys are different than pharmacy students in a really good way, in that you're like interested to hear me talk and they're sick of it. So it's a nice change of pace. So I'm a pharmacist by training. So I actually did, after graduation, my residency here before I became a faculty member, and worked with Virginia Garcia downstairs, and have been practicing at the Beaverton Clinic for a while. And so from a pharmacist perspective, what that means is we kind of help patients manage their chronic diseases. So the physicians or PAs will refer them to us, and we kind of work with them on getting their high blood pressure, diabetes, depression, anxiety, asthma, COPD, those things better managed and controlled. So my role with the school now is I serve as our assistant dean of student affairs. So that's more like helping students manage their things through the program, kind of extracurricular stuff. So my interest in psychiatric disorders really is that I'm a primary care pharmacist by training. So especially at Virginia Garcia, patients have everything. So like they don't come just for diabetes, or if they are coming for diabetes, they also have lots of social and behavioral health things to work through. So being involved in primary care in any capacity and having some awareness around mental health and the treatment options is always a good thing. So for the framing for you guys is definitely, these are some common drugs that we see in primary care that you likely will see in the dental chair. And I tried to highlight some drug-specific things that are unique to your perspective. So some things that are helpful to know about side effects, especially, when like maybe orthostasis, for example, that when patients need to get up and down, and some maybe drug interactions to be aware with, like epinephrine and things like that. So we'll kind of move today pretty quickly through a number of different psychiatric disorders. We obviously could spend hours and hours and hours talking about this and talking about each and every one of them. So this definitely is a very high level overview, and in a lot less detail than I give the pharmacy students. So don't think like I'm delivering you the exact same thing they're expected to know. So really, we hope by the end that you're just able to kind of recognize medications used for these different disorders. One thing I'll keep saying is that you can't make any assumptions, especially with mental health. And that's a really good piece of advice I want you to hear, especially since you will be working with medication lists in your practice. When you see medications on that list, it's easy to be like, oh, well, this person must have schizophrenia. You don't want to make those assumptions, and kind of what the patients share with you, what they're using their mental health disorders, what they're using their medications for. Some of them may not be using them for mental health reasons, or at least that's what they are told. So to let them kind of drive that conversation and not ever kind of use the branding of, oh, is this your psychiatric med, or is this your depression med, or your mood med, or your schizophrenia med, and kind of let them tell you what they think they're using it for, and then that helps you drive the conversation. So recognizing some meds, kind of understanding some basics around mechanisms of action and how they work for each class of medication. I'll definitely be talking in classes today, not talking about really individual drugs. And obviously some common side effects and some potential relationships to dental complications. So we'll go through, there is some overlap of these medications that we use in different disease states, for example. So for depression and anxiety, we'll talk about essentially 3 different groupings of drugs: our SSRIs and SNRIs, our TCAs, and then our host of kind of other things that we use adjunctively. The ones that you might be most familiar with for anxiety, benzodiazepines, and we call them Z drugs, although that name has sort of moved away. We don't use Z drugs as often. So one Z drug that you might be familiar with is Ambien. Since it's been out, comes with lots of kind of scary side effects. And so most providers, specifically at BG, we don't prescribe it. So it's being used less and less. Bipolar disorder, so mood stabilizers and antipsychotics, and schizophrenia, we'll see antipsychotics again. So again, we'll move through each of these sort of in order. So depression. So one of the, I think, biggest things to be aware of when we're talking about medications for mental health is that in general, they're working on our various neurotransmitters. So if you understand which neurotransmitter it's working with, then you can kind of help predict what side effects you might see to some degree. But unlike a lot of our other disease states, it's a lot more gray area in how the drugs are actually working and how we expect to see how effective we expect that they're going to be. But really generally, we expect with depression that our neurotransmitters are just sort of out of balance in some way. So between serotonin, norepinephrine, and dopamine, if they're not all physiologically appropriately balanced, that might result in a mood disorder. And so our medications target a variety of these 3 neurotransmitters, and that kind of results in the different drug classes that we have. So the way the drugs work, and I have this in the way, so let me see if I can move this. Yay. The drugs work by essentially creating a mechanism to allow more of that neurotransmitter to remain in between the neurons. So there's a number of different pathways that affect this. One is, which I think is the most common, is reuptaking. So our selective serotonin reuptake inhibitors are going to prevent serotonin from leaving this in-between space in between the neurons. So increasing the concentration of that neurotransmitter here. Because the thought is, in someone that has depression, is they are deficient of that neurotransmitter in this area. Some other mechanisms is that the drugs maybe turn off the enzymes that break down the neurotransmitter, or prevent the just the breakdown of that, either through breakdown, reuptake, or by affecting those proteins. So some symptoms around major depressive disorder. We pulled this from DSM-5, which is kind of our big diagnostic guideline around mental health disorders. So some symptoms that you may be aware of. So depressed mood, certainly. But that usually comes with some other telltale signs like associated with decrease in pleasure of activities, weight gain, sleep changes, feelings of worthlessness, poor concentration, thoughts of death, fatigue, or loss of energy. Probably students in a program like this have felt many or all of those symptoms kind of throughout your time in a program. And so really screening is super important for depression. Having some record of the timing of these symptoms and how frequently they're occurring. So it's really common, especially in primary care where dental is associated with. You might be doing some PHQ-9 or PHQ-2 screenings where you might just be asking your patients, have you had any thoughts of feeling down, depressed, or hopeless in the last 2 weeks? Or have you had any thoughts of hurting yourself or others? Just to do some quick screenings, because if they say yes, that's a great triage right to primary care. But some treatment options that we have, if we do have a patient that has depression, we have our selective serotonin reuptake inhibitors. We have selective serotonin norepinephrine reuptake inhibitors. Tricyclic antidepressants, which are a little bit older and kind of our old school class of drugs. And then we have some others. One rule of thumb for everything on this list that we're going to talk about is that it takes a long time for these drugs to work. So it takes up to 4 to 12 weeks for patients to see the mood benefit of any of these medications. And so a lot of our patients that start out get really frustrated with these drugs are not working, I'm not seeing it. And sometimes they report it's actually worse. So some will report increases in anxiety over these first couple of weeks. So especially if you're working closely with some patients and they mention to you that, you know, they have just started some of these medications and are maybe voicing those concerns, you can kind of have in the back of your mind that, yeah, these are going to take a long time to work. And sometimes just that reinforcement from the healthcare team in general can be really helpful to them with sticking to it. So the mechanisms for these are all very similar. They just work by focusing on a different set of neurotransmitters. So our SSRIs, for example, you might be familiar with some of these names. Sertraline, paroxetine, fluoxetine, escitalopram, and citalopram are just some. There's a lot more now, but I'd say these are probably some of the most common. I'd say Prozac has probably been around the longest, and so it's still used pretty well. From a pharmacist's perspective, I never prescribe paroxetine, the one I hate the most, because it tends to cause people the most side effects, and if they have to stop it or do miss some doses, they feel really icky. So not my fave. But they all work pretty generally the same. So how you decide what patients start which one is really kind of based on maybe their history, whether or not their family members have tried an antidepressant and trying to start with the same ones. But usually it's trial and error. So you try one, see how they tolerate it. If it doesn't work, you kind of move around the different classes. But they all work the same by blocking that reuptake of serotonin and really increasing that level of serotonin in between the synapses. So our side effects for it are variable. The big one that I think is important to be aware of for all of these is that there's a suicidal ideation black box warning for all of these drugs, specifically for adolescents. So that really just means that they need a lot of monitoring when these drugs are started, especially in that first month, to make sure that they're not having that. And if you think about that, it kind of makes sense. When you're depressed, you're generally more apathetic and less energetic. And when we start these drugs, often it gives some of that energy back, but we remember it takes 12 weeks to see the mood benefit. So you're essentially giving someone that's depressed a little bit more energy. And so that might result in them acting on suicidal thoughts that they may have not had the energy to act on before. And so having those monitoring and check-in sessions are really important. And so that presents itself most commonly in adolescents and kind of young adults, early 20s, but really is a good monitoring practice always. It doesn't mean it will create the suicidal thoughts that maybe weren't there, but that's also not impossible. So, or at least helping or creating, maybe not creating the thoughts, but creating the space for those thoughts to kind of manifest and develop. Some other things around side effects here, GI discomfort, so kind of nausea, especially nausea, especially around the first couple of weeks. As we start to increase the doses of these medications, people will report that. Some people will report that because of that, it also has decreased appetite, maybe some weight loss, but symptoms that are very hard to tease out between what's depression and what's the side effect. And that's always very true for all of our mood disorders. Some people will also report these medications are causing sexual dysfunction. but generally that's often associated more with the mood disorder than the drugs itself. So some additional things to be aware of, especially for this class of drugs, is that it has been associated with some increased risk of bleeding, which I think is important for you guys to know, because the bleeding is usually rather small things. So like gum bleeding, for example, more easily bruised, especially if you're combining the use of these medications with NSAIDs, so ibuprofen, naproxen. So again, really relevant to you in that if you have patients on these drugs and maybe they're leaving their appointment with a new prescription or recommendation to take some ibuprofen, it might be good to know that they might be at an increased risk of bleed. So this is like a young 34, 40-year-old, probably not a huge deal, but in your elderly patients might want to be aware of that. Our next group is SNRIs. So essentially all we've done with these drugs is they're basically SSRIs with the addition of us also affecting norepinephrine. So anyone know what norepinephrine is? Like what do you associate it with? Yeah, kind of flight or fight, right? So adrenaline. So what are some side effects you might expect if we're like increasing heart rate? Yeah, so maybe increase on heart rate and blood pressure, and that's exactly what we see. So these drugs are less sedating, generally more activating. So they're not great options in my mind for patients with anxiety because they are already activated. So giving them things that are activating, not so great. So for our depression and anxiety people, maybe more SSRIs than SNRIs. But these do help a lot with those depressed patients who are kind of lacking energy, right? And really are struggling with maybe doing the day-to-day. These can really help with that. And we actually have a lot more now added to this list that have helped or have tried to come to market. So really the thing is to know that, similar to SSRIs, except we're also, in addition to serotonin, affecting norepinephrine. And as a result, the side effects are the same, except we also see an increase in blood pressure. So we'll notice the list is identical. We don't really see the bleed risk really, for whatever reason. I think it's more of a elimination hepatic thing that we see. But some other things about this drug class is that we also use it for neuropathic pain. So especially duloxetine, use it pretty commonly for patients that have diabetic neuropathy or struggling with just some other neuropathic option. They tend to be a little bit more expensive than gabapentin, which we'll talk about a little bit later, as used in mood and seizures, but is also really helpful in neuropathic pain treatment. So patients with fibromyalgia, you also might see them on this, especially since neuropathic pain is often really closely associated with mood disorders, although not mutually exclusive. So big take-home point, these increase blood pressure. TCAs. So these were some of our earlier antidepressant options. So you can think of these as being older, and of course, since they're older, they come with a lot more side effects. So as we develop drugs, we try to get rid of the side effects. Doesn't always work, but that was the hope. So these worked also with serotonin and norepinephrine. They tend to also hit a bunch of other receptors, and so they're also messing with other neurotransmitters, even though these are the ones that they were targeting. So as a result, they also have some more side effects. The issue with these is the patients generally can't tolerate the side effects very much. So it's very hard to get them to doses that actually impact mood. And so a lot of the reasons that you'll actually see patients on this is they're using it as an adjunct or an additional medication to help with mood, or they're using it for sleep. So amitriptyline in general, especially that one, is often prescribed for helping patients sleep. Sometimes even your older patients will have lower doses of that to try. So one of the reasons that this drug class comes with a lot more side effects is it is an anticholinergic drug. Does that resonate with you guys? So what does anticholinergic mean? Slud. Okay, what is slud? Tell me. Oh, great. You're using fancy words. Lovely. Yeah, okay. I mean, I usually just tell pharmacists to think about you can't see, you can't spit, you can't pee, and you can't. Yeah, exactly. You're all set. So these come with those side effects. So especially for you guys being really aware of the dry mouth, it's really very significant. I think patients will report feeling cotton mouth and wanting like biotin or something like that to really help them with that side effect. But because of the anticholinergic properties, that also makes it so that, patients can report feeling rather dizzy. It's important, especially when they're first starting these, to be careful about orthostasis. We know what orthostasis means. Yeah. So like when our patients are getting up slowly, there's a drop in blood pressure, and so they might get dizzy. It's important to kind of make sure, especially if they're getting up and out of the chair, that they don't injure themselves and moving kind of slowly. So side effects, dry mouth, definitely. I do have a note on here, which I think you guys know what it means way more than I do, about needing to limit the use of dental epinephrine with these drugs. Again, thinking about that they're anticholinergic and really drying, it can cause dizziness. I think that makes a lot of sense. Some other antidepressants that you may see that are pretty commonly used, bupropion. It's also really used for smoking cessation, and in recent years, also weight loss. It's thought that it can really help combat the addictive tendencies that are associated with kind of overeating as well as smoking. So there are some combo drugs with it now to kind of help both of those disorders. It works by working on dopamine and norepinephrine, so no serotonin, so slightly different in terms of what it's acting on. But because it doesn't work on serotonin, it's a great addition to therapy. So you'll definitely find patients that are on SSRIs and bupropion together. So I mentioned earlier, some people report having like sexual side effects with SSRIs. We often use bupropion to also counter that. So the use of bupropion can sometimes treat that sexual dysfunction associated with the other drugs. Also comes with some dry mouth and possibly increase in blood pressure as well, because it's also working on norepinephrine. Mirtazapine, I can't say we use it a ton in the general population. I'd say we use it more in elderly and oncology. So mirtazapine really helps increase appetite. And the reason we don't use it in the general population is it causes weight gain, and no one wants that. So, and it causes some pretty significant weight gain because of that increase in appetite and kind of lack of satiety. So that's one of the reasons it's really helpful in cancer patients, is it's really helping to stimulate their appetite during treatment. So one of the reasons we use it. It's also pretty sedating. So another one that's helpful if our patients are having trouble sleeping. Trazodone, pretty exclusively used for sleep, but I would say it's a great adjunct. So in general, it'll be used along with some of your other antidepressant medications, but can be used without depression, just to kind of help patients with their sleep. All right, so we'll talk about mood disorders next. Any questions about the antidepressants we just talked about? Good rule of thumb while you're studying is really just understanding what neurotransmitters, that helps you understand the side effects. So mood disorders and bipolar disorder, we always think about I think of it about, adding on some additional symptoms that our depressed patients have. So for primary care, it's often really difficult to diagnose bipolar disorder because you're generally only seeing patients when they're on the depressed side. Most patients aren't reporting their mania. They're usually they love their manias. It's like a really productive time for them. They're getting a lot of things done. They're in an elevated mood state. So they're not coming complaining about that. Their family members are. So it's often really difficult to get a good diagnosis. And so as a result, it's often difficult to get them treated. And one of the risks with bipolar disorder specifically is that if you kind of give antidepressants to someone who's bipolar, you basically can swing them into a manic episode because you're treating the depression without any mood stabilizer on there. So the main hallmark for treating bipolar disorder is our mood stabilizer options. And there's so many different subtypes of bipolar disorder. There are people that never really get outside these extremes and stay kind of in the moderate side. There's something called rapid cyclers, so people who move through mania and depression sometimes within the same day. But the typical presentation is that they can spend days to weeks in a depression and days to weeks in mania. But again, there's a lot of different variations on what that looks like and different subtypes that exist. So some really basic rules of thumb is if they're in an acute episode, we generally want to treat the acute episode with the caveat that if that acute episode is depression, then we're likely going to swing them manically, but that might be okay if we're also monitoring them closely and getting them started on a mood stabilizer quickly. So maintenance therapy is really to prevent the relapse into an acute episode of either depression or mania. And we use our mood stabilizer, sometimes along with antipsychotics, to help with that stabilization. Sometimes you will see patients that are kind of on all three. So maybe a mood stabilizer, an antidepressant, and maybe an antipsychotic when necessary. It really kind of depends. We really have tried in the last maybe 10 years to decrease the antipsychotic use because those really do come with a lot of side effects, especially metabolic side effects, which we'll talk about really shortly. So, but first, we'll talk a little bit about the mood stabilizers. These drugs generally are ancient. They've been around for quite a while. Did you have neurology already?
We did neurology right before spring break.
So do you recognize some of these drugs? Some of them are seizure meds. So we talked probably about valproic acid, carbamazepine. So all of these drugs were used and still are used to treat seizures. And that's kind of how we determined they helped with this. It was kind of discovered as an accident that these drugs also help with patients that have bipolar, which we saw when we were treating people that had seizures. And so again, if you think back to neurology, these drugs have a lot of monitoring that goes with them. We have to check drug levels regularly. They're really difficult to keep in therapeutic range. They have lots of drug interactions. There's people whose job it is just to kind of manage these drugs. Until we had lamotrigine made. So Lamictal, lamotrigine does not require all of that monitoring. We don't need drug levels. It requires a titration, but in general is much better tolerated. So nowadays, I would say for seizures, it's most common to see patients on lamotrigine. But you'll definitely see some of these other drugs around. And kind of similar to what I mentioned at the beginning, we could not tell you why a patient might be on these drugs until you hear from them or see their medical history. You can't make assumptions about whether it's bipolar or seizures or whatever. And you can imagine if you're a patient and you make that assumption, the connotation associated with bipolar might feel very different than seizures. And so you definitely run the risk of possibly offending them or getting them anxious about what kind of drug they're on when they thought it was for completely something else. These drugs also have an indication for migraine prophylaxis, so that's another reason they might be there. And the seizure mechanism is sort of similar to the migraine one. You notice especially for all of these older drugs, the mechanisms tend to not be well understood. So for lithium, I have 7-Up on there because 7-Up used to actually include lithium in it, and it's one of the original places that this drug used to. But it's a narrow therapeutic drug, so we have to do lots of blood monitoring. It definitely is associated again with xerostomia. So kind of making sure if your patients are on these that you're kind of especially checking and that they're having regular dental follow-up for dental caries, candidiasis, periodontal disease. They also, it is required that they kind of drink a lot of water with these drugs, and so often patients tend to show signs of dehydration. We don't do that very well. Myself. Also can see some abnormal tongue movements with these medications. Again, orthostasis. We tend to not recommend patients use NSAIDs with these drugs, especially if they're not using them regularly, which we kind of hope no one's using NSAIDs regularly, but the use of them occasionally can mess with the lithium levels. So if they are needing to use them, it's important to kind of loop their primary care in so that they can get some additional monitoring to make sure that they're staying in their therapeutic levels. The caveat I have with these drugs and their monitoring is that they're neurotherapeutic and require close monitoring for seizures, because we don't want someone to move out of the seizure threshold and have a seizure. So for bipolar, though, they don't have seizures and they're not in a therapeutic range, the risk is much less. Like, yes, they might not be as well controlled for their bipolar, but we're not worried about throwing them into a seizure. So yes, these are narrow therapeutic drugs. They're more narrow and it's more concerning for seizures, less concerning for bipolar. Similar thoughts along for valproic acid and carbamazepine. Some differences in some of your dental considerations. I don't think you need to worry too much about the mechanisms, to be honest. We don't really know how those mechanisms are generally associated with increasing effectiveness. Other than this, valproic acid works with GABA, and you can kind of think of GABA as like your satisfaction and I don't know, stabilizing, calming neurotransmitter. It's really effective, especially for patients that have kind of an anxiety component to it. But for valproic acid, it does impair platelet aggregation, and so as you'll see a theme of these, we're really trying to avoid use with NSAIDs and aspirin, because that already is going to kind of add to their impaired platelet aggregation. So similar to all of these, they should have blood levels drawn regularly. There's also some antibiotics we're going to avoid with carbamazepine. It's mostly your kind of macrolides like azithromycin or clarithromycin that we're concerned about. But again, especially for bipolar disorder, probably just a note to the primary care doctor. Probably not a huge issue to use it, especially for a short 3 or 5 day course. Again, we're not worried about if they're not in therapeutic range, them having a seizure. So again, really important to know that difference of what we're treating if you're seeing these drugs. I'm much more concerned about the monitoring and the side effects if they're a seizure disorder versus bipolar. So I mentioned my favorite, lamotrigine. It's my favorite because look how little side effects there are. And we don't have to worry about the monitoring. It works really well. It's definitely increased in popularity, mostly because of the ability to not need to bring patients back to get blood draws. Super awesome. Biggest side effect to be concerned about is orthostasis. The other is a rash, and the rash is really associated with moving up too quickly in the dosing. Or for patients that are on higher doses and they stop taking it and then resume their higher doses, they can get a rash without titrating out. So orthostasis is the probably big thing for you to be aware of. So those are our mood stabilizers. Then we kind of think about having adjunctive therapy to assist with anything that is being experienced, even if they're on a mood stabilizer. So we can think about for our mania symptoms, we can essentially try to calm them with their manic symptoms via use of antipsychotics. And we'll talk about antipsychotics when we talk about schizophrenia real shortly. But we can also use antidepressants that we have just talked about along with the mood stabilizer and patients that maybe have some debilitating depressive symptoms despite the mood stabilization. I kind of think of the mood stabilizers as like turning down the volume. Like it doesn't resolve the bipolar, it just kind of helps make it a little bit more equivalent and slow those maybe rapid cyclers, or help decrease the huge difference between the bipolar symptoms. But that doesn't mean that they won't still have side effects and need to kind of, or still have symptoms and need to treat additional. So it's often to sometimes need to use antipsychotics or antidepressants in bipolar disorder at specific time points. And so they might not be on antipsychotics continuously. They might not be on antidepressants consistently, but they may need to add that back occasionally depending on where they are in their progression of the disorder. So schizophrenia, psychosis. Psychosis is a really large umbrella term. In general, we're thinking about gross impairment of thought and behavior. The patient is really having a hard time differentiating between real and hallucinatory thoughts. Anyone see, it's like an older movie now, A Beautiful Mind? Yes, so that's a great example of someone with schizophrenia. However, in the movie, you notice that they have a lot of visual hallucinations, right? That's very much for cinematic effect. Most patients with schizophrenia and psychosis do not have visual hallucinations, they're auditory. So generally they're hearing voices. In the movie, he was like very directed by his hallucination of, you need to do this, you need to go there, and you I'm going to tell you these things about yourself that maybe are not true, and the paranoid nature about being followed, and that there are spies around him, are very similar to what patients experience, just kind of minus the visual component. So we kind of divide our schizophrenia symptoms into positive symptoms and negative symptoms. And I think that's kind of weird terminology, but what we mean by positive symptoms is, I like to think of it as things that are there that shouldn't be. So things like hallucinations, delusions, paranoia, being super suspicious of everybody. And then your negative symptoms, which means you're kind of lacking, in my opinion, lacking something. So social withdrawal, lack of interest, and really severe schizophrenia can lead to catatonia. So I did spend some time as a student on a psych ward in Maryland, and we had quite a few patients that were catatonic, and I had never seen that. And it's quite, I don't know what the word is, humbling. They are existing, but are not responsive to like anything because they're so deep in their mental disorder. And at that point, the only treatment that I've seen that works is ECT. Anyone know what ECT is? Electric convulsive therapy, which also in media looks very violent, but is absolutely not, and is very calming. And we actually had so many patients that were schizophrenic and know when they have their symptoms that they need ECT, and would come in just to say, I'm ready, I need my ECT, and then would leave, like completely different people. Magical. Yeah, so the thought is that it kind of resets the neurology and the brain chemistry with electric convulsive actions, but there is no violence to it. So it's not like people are sitting there like, whoa. That doesn't actually happen. They give them some sedatives. They only leave an arm They actually tie a blood pressure cuff to the arm so the drug doesn't get to this part of the arm, so they can see the seizure that it induces, just to kind of make sure that it happens. And then after that, they wake up and they're really tired for a little bit, but they end up leaving really great. So there's a lot of great evidence for ECT, and especially in this either severe depression or schizophrenia that is not responding to drug therapy, it's a great option. Or maybe it's patients that can't handle the drugs. It's possible. Yeah.
Why is it these considered positives?
So I think it's confusing. They're not positive in that they are good. It's just I interpret it as they are symptoms that they are present. So kind of think about like in a physical exam, you would say they're positive for these symptoms. I think it's really similar to that, in that these patients are positive for having these additional things present. Like they are having hallucinations, they are having delusions, they are having suspiciousness.
Like in their best state.
Yes. And generally that's going to exist at any time. So even once they're treated, most patients with schizophrenia still have the hallucinations and delusions. They don't ever go away. They learn to deal with it. And they just kind of mutes those voices, is what I've heard it being described as. So the other thing I'll point out kind of on my soapbox about schizophrenia, this is where a lot of our homeless population is. They're not getting treatment, and so they're dealing with these hallucinations and delusions all the time without appropriate therapy. And it's very difficult to figure out how to navigate the healthcare system or navigate getting yourself treatment when you're trapped in this world of hallucination. So very, very difficult disease state to manage. It really requires early intervention, and most patients will get diagnosed in their late 20s. So it's usually when it starts to manifest is in that time frame.
Is this can be developed later, or is it usually people are born with? Or can it be developed?
I think that's really it's very much debated where and how much is related to what you're born with. And I think there's obviously some genetic component. You'll find it runs common in families, but there's definitely a huge environmental factor. And so the fact that most patients, regardless of their family history, won't exhibit any symptoms until they're in their late teens, 20s. The earlier diagnosis is definitely associated with trauma. So the more trauma, the earlier it's diagnosed often, or at least those first symptoms are identified. So often where I've talked with people that have been recovering addicts, the reason they became addicts was to calm the voices. So they were just self-medicating when they had no other options. And so, I don't know, I think really understanding this disease state really does shed a lot of light on addiction. Very separate topic, but I think that there's a lot of overlap and thought between, how being addicted to substances can be related to just not having other things treated. And I don't think that's just schizophrenia. There's lots of things. But anyway, we don't have time to talk about that now, but I'd love to. Antipsychotics, I think, is probably the most important thing to talk about here. It's really our only types of drugs that we have to treat psychosis in general. But these drugs are complicated. They come with so many different side effects. So we kind of have our first generation antipsychotics. They work by kind of blocking dopamine. So if you talked about neurology before, we may have talked about Parkinson's before, which is actually the opposite of this, right? So when we have a patient that is kind of lacking dopamine, they have this Parkinsonian-like symptoms. So in Parkinson's, the treatment is to increase dopamine. And so some of the treatments that we give facilitate that, prevent the breakdown of it, or actually synthetic versions of dopamine. In psychosis, the thought is that there's too much dopamine, and with too much dopamine comes hallucinations. And so think of it kind of as a spectrum. When you're treating Parkinson's and maybe you overdose them, their side effects are possibly hallucinations. And then we're treating someone that has psychosis with antipsychotics, the desire is to decrease the dopamine. And as a result, the side effects are Parkinsonian-like symptoms. So specifically, our first generation antipsychotics, most commonly probably seen as Haldol, will come with these side effects that are associated with these extrapyramidal symptoms, which are related to this decrease in dopamine. So sometimes these are reversible, not always. Most of the time they're reversible once we kind of get them stable. But one of the reasons these medications are really difficult is because they come with these additional side effects. The industry tried to come up with how can we treat them without these kind of debilitating side effects. Enter second generation antipsychotics. So did we get rid of that completely? No. So it's still possible to have EPS symptoms with second generation antipsychotics, although much rarer. The issue with these drugs is that they all cause a significant metabolic side effects. So increases in blood sugar, increases in blood pressure, increases in cholesterol, increases in weight, and they also tend to be super sedating. So you'll see a lot of these drugs used inappropriately in nursing homes to calm patients down. Especially Seroquel. You'll see Seroquel used a lot for sleep. That's pretty inappropriate. It's an antipsychotic, but it's very effective at helping patients sleep. However, they come with these very, very significant side effect profile. So I mentioned that they have, metabolic side effects, but they also have some of these other things I think are important for you to know. So dry mouth, certainly. Clozapine is one of the most effective second generation antipsychotics, but it also comes with this agranulocytosis side effect, meaning it needs some monitoring. And as a result, it can also present with a bunch of other dental related side effects, which is what's in orange. So it's very rare for patients to be on clozapine unless they have kind of failed all other treatment because of that.
Are those second generations, are they supposed to take them daily or and give them like as needed? Might they say take this if you're having trouble sleeping?
They will. That's pretty inappropriate, I think. But it has been prescribed that way. Most pharmacists that I know will call the provider and be like, if we need to use something as needed, can we use something else? But in general, it's not recommended to be used that way, but it is used that way quite a bit. Yes.
Like Risperidone?
Yes, Risperidone. So especially if you're on the inpatient side, these come in many formulations, like intramuscularly, and you can be giving it sub-Q, I think, some of them. So they'll use them, especially in the psych ward, to initially calm patients down rather than using benzos or something along those lines.
My sleep doctor told me that a lot of patients who have sleep disorders like narcolepsy or other sleep disorders can be misdiagnosed with depression.
Yeah.
And then the medications that they're given for depression can make their sleeping
Worse. Yes.
when they sometimes don't ever relate the two.
Yeah, I would say that's pretty common. I think misdiagnosis in general for kind of all mental health disorders is their sleep is difficult because there's so much factors that go into sleep that can be affected by those different disorders. So that kind of leads me to anxiety and sleep. There's a lot of other things that I don't include here that have come out in the last couple of years around sleep. There's been a lot of new medications for sleep that are much better tolerated too than some of these. They're just very expensive. So they're still relatively rare for patients to be on at this time. Anxiety, So there's so many different types of anxiety disorders that we could talk about. Generalized anxiety disorder probably the most prevalent, especially in primary care. All the drugs that we've talked about, especially when we talked about depression, essentially can be used in anxiety as well. So in general, the treatment algorithms and how you treat anxiety and depression is relatively the same, with the caveats of the ones that maybe are more activating, maybe not first line for anxiety. GABA, I mentioned, is a major inhibitory neurotransmitter. So drugs that increase GABA effects usually result in sedation, relief of anxiety, and then short term, many of them can be used also for seizures. And so the drugs that I'm thinking about here are mainly our benzodiazepines and other anxiolytics. So very, very sedating. Again, very almost anticholinergic in that they have lots of side effects. Tend to have like a muscle relaxer effect. Really large potential for addiction or abuse associated with our benzodiazepines, unlike everything else that we've talked about so far. None of those generally have any addictive properties. There might be some dependency, but not from like a symptomatic, more like a physiological response. The potential of abuse, addiction and abuse with these drugs, we really want to be cautious on our elderly patients because of all of the side effects associated with them. Commonly known as benzos, you guys are probably familiar with these, being in the dental field, often given as needed prior to dental visits to kind of calm patients down before they come in. Just kind of a word of caution is that they have various different half-lives. And so I would say the most kind of appropriate for like prior to a visit are these intermediate acting. So kind of your lorazepam and alprazolam. When we get higher, so longer acting, those are gonna kind of be effective all day for those patients. So really thinking about how that's going to affect them if they're taking them just for an appointment. We really kind of reserve Librium for patients that are detoxing, and that's really where that drug is used the most, specifically in alcohol withdrawal. Especially since these also have some anti-seizure properties. That's another reason that one's used in alcohol disorder. So for these ones, it might be helpful to you to know a little bit more about that mechanism of action and duration of action time. The other big dental thing to make note of is that benzos can also be used at bedtime to treat nocturnal bruxism. Although the recommendation that I have read is that it shouldn't be used for more than 2 weeks because of the abuse potential. And so again, just kind of close follow-up there and kind of working with their primary care team to determine what also could be considered. TCAs can also be used. We mentioned them earlier as well. Again, not a great side effect profile. So between all of these drugs, it might be difficult to find what works best for that patient and is the safest for them. Let's see. Make sure they have a driver. If you're getting them on benzos for their appointments so that they're able to leave the appointment safely. Non-benzos, but are very similar to benzos, is our Z drugs. So Zolpidem, Lunesta, Sonata, we have a bunch of others. Really, I'd say is still there mostly. It has a lot of the similar side effects. We definitely shouldn't be using these drugs in office for sedation, which you can do for benzos, mostly because these are going to be much longer acting because they're meant to work throughout the night. And so you're also not going to usually get the immediate action that you would get with the benzos. So really shouldn't be used as an in-office sedative, but works very similarly to some of the benzo medications that we talk about, although they don't generally help anxiety because they're working at a different location than the benzos are, but we're getting all the sedation effects, which was somewhat intentional. So they were designed to kind of provide the sedation that the benzos do without necessarily affecting mood. That's resulted in likely having really scary dreams, is mostly what people report. Some other drugs that are on that you might see. So trazodone we talked about earlier is really used for depression. Also can be used as a kind of mild sedative, but generally is well tolerated. Buspirone or Buspar, which is different from bupropion. So we talked about bupropion earlier when we talked about adjunctive depression meds. It works for smoking cessation and weight loss. Buspirone is used primarily for generalized anxiety disorder. And one of the barriers for patients is that it has to be taken 3 to 4 times a day. So pretty frequent dosing, but very effective at managing. And then one of my favorites is hydroxyzine. So one of those as needed options. We kind of use it, especially at BG, we use it instead of benzos. So we will give it as needed, kind of to help patients in the moment for when they're having an anxiety attack. It's very effective. It's very similar to Benadryl. Actually, it is an antihistamine. So it's really the calming and drowsy effect that we get from that, without the addictive potential of the benzos. So it's a great another option that we can use for anxiety, or also sleep, but generally anxiety is needed.
Does it make them so drowsy that it feels like really sleepy, like well?
Not as much as Benadryl, so safer than Benadryl. But I've noticed patients don't have as much of the drowsiness and just more of the calming associated with it. Not so much that they need to go to sleep, but that varies a lot by patient to patient. And that's all I had. So what questions did you guys have? Yeah.
For the, was it that SSRI and the are both, do both of them have the initial side effects of
Yes, I'd say it's more prevalent with SSRIs. Mostly just because of who we end up using those different drugs in. So the SNRIs, if you're really concerned about activating those thoughts, we probably wouldn't consider using the SNRIs because the nature of those drugs they're increasing energy by nature. So yes, I think the potential is there for all. I would just kind of note that always. Mm-hmm.
I have a question, but I want the student, I don't know, if it's a student question. It's them first. But so these last one, or the other agents at the end, so none of the acetone or the Buspar, those don't really have the addictive?
No. I think you'll hear some discussions about trazodone specifically. But especially if it's used and the doses as recommended, it doesn't generally cause an addictive personality or cause any dependency. Most people are really just enjoying its ability to allow them to sleep. There is some I'm blanking on the word that I want to say. You continuously need to increase the doses over time for it to continuously be effective. So there's some tolerance, thank you, that comes with it. And so for trazodone, it's usually effective at lower doses for sleep. To get any benefit for mood, you usually have to get up to like 200 milligrams or so, and it starts at 25. So there's a huge range, where you could see sedative effect. But if you're really looking at it for helping with depression, it's going to take them getting to those really higher doses of it. So often patients can be on trazodone for a long time and slowly kind of titrating them up.
Does trazodone work the same way as like other frequency for that long before it starts like effective or does it work?
For mood, yes. For sleep, no. So the sleep effect will be like right away. The mood disorder will take weeks. Also, yes. There's one here.
Is your relating? to
No, kind of.
Either one.
What's the milligram difference between like for sleep and depression?
Yeah.
25. and
If there's
200?
no like, this is the dose for sleep and this is the dose for depression. If we're using it for sleep, well, really for anything, we're going to start lower because we can't predict how they're going to like experience it.
Mhm.
So we'll start low. Our goal is helping with mood disorder. We shouldn't be using trazodone by itself for that. It would be with one of the other drugs. We would maybe increase it faster. But in general, the inhibiting factor is the drowsiness. So it's very unlikely most patients will get up to the doses needed for mood disorder, which is 100 to 200 milligrams of trazodone to really get to the mood disorder.
Got it.
Some people are on that dose for sleep, like my mom is at that dose for sleep. But some patients will at 50 be like, oh my God, I'm knocked out and I like can't go anymore. So there's a lot of variables.
So would it start to be like
25,
Okay.
yeah. 25.
Thank you.
Mhm. Good questions. Yeah.
Is ADD and ADHD under psychiatric?
Yes, it wasn't part of this topic.
We'll have to add it
Mhm.
next year.
Yeah, I feel like there's someone else that has always talked about it. I don't know where.
But
Stimulants,
are they
if not,
comparable?
I wouldn't say yes. So there is nothing on here that we've talked about that would be used for ADHD. We really would be thinking about stimulants for that. There's now also meds that are not stimulants that also treat ADHD. So yeah, there's a whole bunch of stuff there too. Yeah.
Well, thank you.
All
so
right.
much.
Thanks for your attention, guys. Great questions.
And we'll take a 10-minute break and then if you guys can come back.